Good evening, everyone, and good morning, depending on where you are. My name is Raj. I'm a trauma and vascular surgeon from Singapore, and apologies for the attire, just scrubbed out myself. And essentially, what we're going to be doing today is just collating we've collated some of the questions that have come in on the Q&As, and some which have been transmitted directly to us. And perhaps once I get everyone on the screen, then I'm just going to go around with some of these questions which have come in. So without further ado, perhaps I can start my first question to Prof. Ken Bofat, and this was a question which was partially asked, partially answered when talking about the removal of shrapnel from wounds, and while the dogma is try to leave everything as they are, unless particular cases where you're worried about whether they've gone into the joints, etc., as answered just now by Prof. But are there specific scenarios where you would go searching and would go removing shrapnel, and any particular subtypes which you think, just for the audience, that we should be aware of to go in to remove?
Thanks very much. I didn't really have enough time to cover the entire subject. I think if it's close to a large artery or a large vein, that bit of metal must be dealt with. But the other thing that I didn't mention is that any missile inside a joint, the synovial fluid is actually quite corrosive. So although that's not for the emergency situation, certainly all joints may need to have arthroscopic or other exploration and removal of fragments from them. Otherwise, we're quite happy to leave bullets behind, certainly in the abdomen, certainly in the chest. They wall off and generally don't cause further problems. So there's never an ever, there's never an always. But our rule is, if it ain't a problem, don't make it one.
I think that's very sage advice there. Thank you very much. We have another question for Dr. Edward Tan, and this is actually with regards, and I think sorry, I'm just checking whether this, yeah, your description of how a separate command and control structure comes in place during a mass casualty created quite a bit of interest. And there were questions about how do you manage having a separate command and control structure? How do you manage to transition from the peacetime structure to that without disrupting your peacetime ops and your care of the non-mass casualty incident patients?
Yes, well, first of all, thank you again for the possibility to speak to you. What we have decided is mostly a crisis or an incident is short. So during that time, the crisis command structure takes over the management of the hospital. During the COVID pandemic, it was not a short, actually, not a short crisis, but a longer crisis. So at a certain moment, we decided, when we were over the height of the COVID pandemic, the first wave, by the way, the board of directors took over the control of the hospital, and we transferred it to another kind of crisis management, but a chronic crisis management. So the essence actually is that during a crisis, you need a quick command and control. And therefore, in our opinion, we have a crisis command structure. So not the board of directors, but a crisis command structure who can quickly decide. For instance, we have to close the ER, or we have to close a building if there's a fire in a ward or something like that. So it's especially meant for the first 24 or 48 hours, and after that, when things will settle, then the command and control structure can be reinstated, the normal command and control structure.
Thanks. And just a follow-on question is, but you mentioned a little bit about how this was in use during COVID as well, but what were the specific changes that you had to institute during COVID, during the different phases to kind of manage mass casualty incidents? And what were some of the learning points that you had? Because I'm sure it must have been a huge challenge trying to manage this in the setting of a pandemic.
Well, as I tried to explain, we have never fully scaled or used our crisis management structure completely. And this was the first time we had to, well, get everything working. So I wanted to point it out. You can always prepare for the unexpected, but when the unexpected happen, you should be there. So it's essential that you practice and that your personnel knows what to do. And well, we weren't expecting COVID, and the good thing is that our system works. And of course, we have smaller incidents. So I showed you there was also a crisis command structure when we got 19 burn casualties, so 4 at the same time, but it was just for 24 hours. And after that, we could step down. And again, experience in civilian hospital or in peaceful countries is very limited concerning mass kills. So you have to go to Yemen or to a war area, a conflict area, I mean.
Thanks, Stan. Just a question, focusing a little bit more on the military aspects, and perhaps I could direct this to Dr. Mansoor and Dr. Tamara. When you have forward deployed elements, how do you draw any lines between paramedics and doctors, or how interchangeable are these roles once you're at the front line? And do you think you can train up a non-doctor or a non-surgeon to take on a significant surgical capability, given the resource constraints and the staffing constraints that you're going to find in the front line?
So I think that Professor Khan and I have joked about this before, that when the US and the UK deploy, it's not a low resource environment. So it's a little unfair to say that, because we do have a very robust military medical force. The services handle the training differently. So I'm in the Navy, and the way that we train our independent duty corpsmen is the same as training a paramedic. So they actually do independent care. And our corpsmen have varying levels of training, which usually is about a 6-month A course, and then they can get more specialized training. And then it's incumbent upon us when we're there to continue that training. And right, that's how we do mass casualty drills, so that everybody knows what to do, where to do, and where to do it. The far forward technology like Roboa, I think that it sounds really good, but I think that we need to approach it very cautiously, because again, it's like clamping an aorta. And so doing it very far forward when you're not going to be in an operating room is not necessarily helping the patient. And certainly I've seen people taking a little bit of knowledge and using it in a way that can be harmful rather than helpful, particularly when talking about decompressing tension pneumothorax with knives. So if you stab somebody in the box, it's not going to help their tension pneumothorax. So sticking with that. So we haven't trained people to do surgery like that, but I will say that in our submarine force, we do train non-physicians to do surgical procedures, specialized surgical procedures, because again, obviously for operational requirements, they can't surface all the time. And so we do have training programs for that. Over.
Thanks, Raj, and thanks, Tamara. So I think a very, very interesting question. And the two additional points I want to add on there are technical skills you can teach individuals, which a lot of individuals can undertake, but there's also clinical judgment, which you can't teach somebody. So it depends what you're talking about far from forward. You can have a really senior paramedic who's been in the armed forces ages, and they will have a degree of clinical judgment which somebody else won't. So you have to know your personnel, and those are the two caveats. You can teach anybody a technical skill, but you can't teach everybody clinical judgment. So that's my two caveats to that.
Thank you. We have received another clinical question, and perhaps, in fact, to be honest, I'll just open this up to anyone who would like to take this. But this is regards to analgesia in the front line. Certainly, morphine auto-injectors were things that we all grew up with in the military, and that was used to be our mainstay. But now with ketamine auto-injectors, intranasal fentanyl, has this started to started to make its way into the front lines in any of your services or in any of your practice fields? So either in a pre-hospital setting or the frontline setting, or are we still at the kind of the old stage of morphine auto-injectors as the key analgesic tool? Dr. Khan? Yeah.
Thank you. Again, my twilight of my military career, we used to have fentanyl lollipops. And the nice thing with having a fentanyl lollipop is, I'll be honest with you, patients need analgesia. It's the most horrific day of their life. And the last thing you want them to have is pain compounded by all the other stressors. So fentanyl lollipop, they suck on it. When they've had enough, they sort of like pass out slightly, but then they can come back. And when they're awake, they can continue having it. So it's the best form of patient-controlled analgesia, rapid uptake, rapid clearance, and targets the pain relief until you can get something more definitive. So absolutely. And there are constant evolutions happening. I mean, if you look at children, you have intranasal diamorphine, a whole spectrum. It's what each country's armed forces is willing to invest in and have the infrastructure to supply.
Perhaps, sorry, go ahead.
Zvonimir Lovrić, I'm asking for word.
Oh, yes, please go ahead.
Okay. May I? Very nice meeting, excellent meeting. But a few comments. Kenan probably did not mention, I think, that Edward Tan is also the member of the Ambrose Paré International Military Surgery Forum for years. Now I would like to refer to Ken Beauford's lecture about shell fragments. I have done a few studies about that 25 years ago. Shell fragment, usually, some of them, according to the military literature, have, we call it muzzle velocity. That means the velocity at the point of the explosion. Sometimes 1,300 meters per second. It is very, you know that, Ken, but I found in my own experience that those shell fragments from various explosive devices are warm, many times hot, red hot. I have seen with my eyes when I was laying on the ground due to the heavy bombing, one such shell fragment fall maybe 1 meter away from my eyes into a small pond, and it was boiling in the water. I saw that. Another experience as a surgeon, when I performed the laparotomy due to polytrauma injury of the thorax and abdominal organs and so on, and we found not so small shell fragment in the abdominal cavity. It was laying on the ureter, and we had another situation. It was laying on a small bowel wall, and we had, with this small bowl, I'm certain that for that 100%, what I'm saying now, we had necrosis of the small bowel wall after 24 or maybe 36 hours. That means that warm or hot, red hot shell fragment can enter the human body and produce another damage, which is burn. Very rare, but it happened. I have seen this. Another one, to my friend Mansur Khan, he didn't mention anti-tetanic prophylaxis as a history of the military war surgery and how it influenced the civilian surgery. But I would comment rather the speed of evacuation. The good speed of evacuation from the field to the hospital or some place where the surgeons are, statistically speaking, increases the hospital mortality. that you know, but it decreases preventable deaths, number of preventable deaths, and gives the chance to those who would probably be killed in action, be called killed in action, to survive. That's the moment. If you are a statistical doctor, or if you are a surgeon in the field, you look at that different way. That will be all.
Thank you very much. Could I invite a comment from Prof. Bofai?
Thanks very much, Raj, and Vladimir, it's a pleasure seeing you again. Thank you very much for your participation. It's difficult to cover everything in 20 minutes. As I said, that short movie clip I showed of the soldiers watching an explosion, that was 1.5 kilometers away, and it covered that 1.5 kilometer, 1,500 meters, in just over a second. So you're absolutely right about the speed of the fragments. The mass of the fragments is important because obviously the heavier it is, the more damage it can take. And then there are 4 types or 5 types of blast injury, which primary is blast, secondary is the fragments, but there's also the quaternary, which is heat. Anything that comes into contact with the blast is going to be hot. And so you are inevitably going to see everything from blast burns to hot fragment burns. And you just have to accept that every single blast injury has components of all of those. So thank you for emphasizing all of that. You're absolutely right. The other comment I would make is certainly in our military, we insist that every soldier has tetanus prophylaxis before they set foot literally on the ground. And I would hope most other armed forces do the same.
Thanks, Prof. Dr. Lovely, you have your hands up.
Sorry, I didn't put it down.
No worries then. All right. Sorry, there are a couple of new questions that have just come in on the Q&A, and just to paraphrase one of them, it's a little bit about simulation training. It was initially directed at Dr. Avi, but let me just open this up to the whole group. But essentially, how do you actually train for combat casual? How do you make combat medical simulation real? Because most simulations tend to be focused on specific medical procedural skills or scenarios, but how do you instill that combat aspect of it during in a simulation for training? I'll just open it up to the whole panel actually for anyone who's keen to chip in.
Maybe I can come in briefly because Jacek, which is owns the DSTC course, is very involved in this. It's interesting that over 80% of all simulation is actually practical skills. And there's very, very little of the remaining 20%. 80% of that 20% is aimed at medical students. There's almost nothing aimed at, the United States has a full-time medical service. Germany has, but very few others do have. They use civilian surgeons who have absolutely no contact really with major trauma, let alone multiple trauma. And so there's a lot of investigation. Jacek is involved with it, looking at artificial intelligence to try and change the mindset to understand when you have competing injuries, not just a single injury of civilian work, but multiple injuries, how to prioritize them. And at the moment, there is very, very little work. And hopefully Tamara will come in as well. Very little work on changing the mindset of the reserve civilian surgeon in the military for dealing with injuries they've never seen before. They know what to do, but they sure as heck don't know when to do it.
Thanks, Prof. Dr. Tamara?
Yes, I just wanted to comment very quickly that, and I appreciate Dr. Bennon's talk as well. is this is why in the US we feel like it's so important to continue military training programs. And I know that Sri Lanka has established the same thing so that you can have that focus and train people, because again, the military, and Dr. Khan has written about this as well, what we are required to do downrange is completely different than civilian trauma. There's not blast in civilian trauma. There's not usually, it's the amount of penetrating trauma is very different. And the way dealing with massive transfusion, it's much, much less. And so it's incredibly important for training programs that we continue to train. If we're going to continue to maintain a military force like this, that we train people in the service with specific requirements for training. Over.
Thank you, Dr. Tamara. Perhaps we just have time for one last question from the Q&A, and perhaps I could just throw this open again to the panel, but perhaps Dr. Ashok, you could take this on for the first part. And it's a little bit about dealing with patients with multiple medical comorbidities when they come in for trauma, given the evolving phenotype in the sense of all of our trauma patients getting older with more medical conditions and on more medications. How do you prepare for that? How do you train your juniors to think of trauma in that particular subgroup?
I think, thank you for the question. I really appreciate that. I think most importantly, I think we need to have a very holistic approach in identifying what kind of trauma this patient has sustained and how we're going to deal with it. However, we have to keep great interest in terms of time management. We cannot delay these patients from going to the operating theater or to the ICU. There must be a good balance in terms of looking at the comorbids and also to look at the intensity or severity of trauma, and then putting all that balance up and getting all the team players, because trauma is not just, it involves the trauma surgeon per se, but it also involves all the other team players to give their opinions on how we're going to manage this patient holistically in order to get a better outcome. So I always emphasize that you don't look at the patient just at the wound or whatever injury the patient has sustained, but look at it as a whole and manage the patient as a whole. I think that's extremely important in order to get a better outcome. But having said that, the trauma will take precedence. The management of trauma strategies will take precedence despite whatever comorbidities the patient has. Having said that, we also look into how we're going to optimize in quick ways or quick manners in order to come out with a good outcome. I hope that answers the question.
Thank you very much, and it sure did. I'd just like to thank the entire panel for answering the questions from the audience, and I think it's been really quite enlightening to see the bit of the to and fro between all of you as well. It's really been quite inspiring. Are there any last comments, Dr. Amila, Dr. Gupta?
Yeah, thank you. That we have had a very great meeting, this initial collaborative meeting between the Ambroise Paré and the Asian Collaboration Trauma. I sincerely pay my gratitude to all the panelists and the reactors and the leadership of the Ambroise Paré and the Asian Collaboration Trauma for successful conclusion of this meeting. Over to you, Raj.
All right. If not, I think we'll close the Q&A segment, and let me pass this back to our two moderators as well.